Um, so I'm going to frame it in the case. So borderline people have intense emotional experiences, um, and uh, and are very much uh, an instability in relationships. And that case history really shows or defines that. It starts in early adulthood, multiple contexts. Um, uh, there's frantic efforts to avoid abandonment, and usually impulsivity that's self-damaging, recurrent suicidal behavior, chronic feelings of emptiness, inappropriate intense anger, and transient stress that can cause, and transient stress can cause psychotic-like symptoms. So, and to help the clinical discussion, many people debate about the border between borderline and bipolar, and borderline has been discussed at least as a variant of bipolar. Um, so, so that discussion about this particular patient is relevant. So next slide, please. Great. Um, so I'm not going to go through this. We don't have a huge amount of time. I did this last time, but I want to just make the point that borderline personality disorder is associated with multiple types of trauma. So usually early childhood trauma, trauma in late adolescence, and then early adulthood trauma. So usually a person with this behavior needs to have at least 3 significant trauma hits during different developmental uh, phases. Um, and this causes significant changes in a person's stress axis and neurotransmitters and even how the brain itself is functioning. So structural and functional consequences. Next, please. Um, so there was a question last time about whether there was a gender difference in outcomes. Uh, and so what I did research this, and there's multiple prospective long-term follow-up studies that do show that patients with borderline personality disorder experience a remission, not in weeks or months or even years, but over a couple of decades. Um, in general, in treatment studies, in mental health, period, there's an overabundance of females. So in any types of treatment studies, there are more females than males. And this is not just in studying borderline personality disorder, it's in studying depression and other mental health disorders. Um, and because females are more likely to engage in treatment. However, the best study, 10-year course of follow-up and treatment, showed there was no gender differences in the course. And that was the only study that I found that actually looked at the gender difference. But so there's no evidence that male borderlines have any better or worse prognosis than female. Next, please. Language is important, and I put the person-centered language in the appendix. Um, uh, it's ideal if patients will accept intensive case management, CCS. In the case that was presented, they are refusing it, but that's ideal. And then for anybody that has had trauma in their background, um, understanding the elements of trauma-informed care, um, trying to develop empathy, focusing on what happened to you, um, is important. Next, please. Uh, So, uh, trauma-informed care, I included a presentation on it with this presentation, so you can take a look at that and review that. The whole idea is creating safe spaces, um, and it's been shown in general, not everyone who's been traumatized, but in general, for groups of people with trauma, that trauma-informed care reduces trauma-related symptoms. Next, please. Um, and it's subtle, but it's important to understand that trauma-informed care changes the viewpoint in terms of not looking. I mean, we can certainly, with this patient's description, we can certainly see her reactions as being very pathological. However, it's also important to try and understand these reactions as having survival values, being adaptive. Um, uh, so, and part of what really is important with these patients is developing some type of empathy. And I know it's difficult, and I know that, and because I had my own experiences, um, but it's important to try and do that. And we'll talk a little bit about this particular patient. And uh, it's also important to focus on the person's strengths um, and and their participation in treatment. And this seems to be the problem in the case we were talking about, is that this patient has made a number of treatment refusals, and it's probably the relationship that is healing in patients with this um, diagnosis. So the refusal to participate in treatment is a significant issue. Next, please. Um, so I did take a look. Language is important. I did. This is brand new information to me. Um, but many people that have been diagnosed with borderline personality disorder uh, considers it as stigmatizing, and um, and there's a specific helpline for people with borderline personality disorder, and that seems to be something that um, it evokes a lot of emotion. Um, and then I didn't know this myself, but I found out that there's actually recommendations on the proper use of language in terms of psychiatric diagnoses. And borderline personality disorder does not meet the standards of being non-stigmatizing. So I think it's important when you're dealing with people like this to actually do a shift in your own thinking. And there's been a couple of different um, uh, alternatives: emotional regulation disorder, or emotional dysregulation disorder, impulse disorder, or interpersonal regulatory disorder have been proposed. Um, and then another one that I particularly like is post-traumatic personality disorganization, which goes along with several of the previous presentations I've made on trauma and how trauma can disorganize and affect personality over the long term. Um, I think that in dealing with a person, as long as you're not, in as long as there's not a documentation problem, I would suggest dropping the term borderline and using one of these that feels comfortable with you, especially in talking to the patient, and seeing if you can find some common ground in terms of what what areas that the patient's willing to focus on and accept. Next, please. Perfect. So it's important. I'm going to just go over this briefly, but it's important to, even though it's trying, to just use basic skills, active listening, respect, patience. So next, please. And so I think that, especially with the case we talked about, and it's important to acknowledge that the person is the expert of their own life, and the idea that, and it's very important for them to feel that they are making decisions for themselves, and I think some of the treatment refusal might be a lack of validation for her ability to make her own decisions. So I would probably want to support her ability to make her own decisions and to validate that. But then, if possible, edge the conversation to, you're making decisions for yourself. That's the right thing. Are these decisions the best for you? Are they the best for you in the long run? So just, and it's important to remember when dealing with a person with this diagnosis that you're not going to get any dramatic breakthroughs in one session or one time talking with them, but it's in building up sort of a relationship and in building up a common dialogue. So supporting her ability to make her own decisions while at least trying to discuss whether those decisions are the best for her in the long run might be a place to start. Next, please. Yeah, so emphasis on emotional safety and avoiding triggers. My guess, the long episodes of yelling on the phone, and numerous calls to crisis services have something to do with emotional safety and being triggered. It's very difficult to interact with a person who's been triggered. So we're going to talk a little bit about that. So it's important to work with a person when they do feel safe. And so especially in initial sessions and initially getting to know a person, always ask if they're feeling safe. Is there anything I can do to make you feel safer? Please let me know if you're starting to feel unsafe. And just discussing what makes a person feel safe or not is a very important relation building activity for people with traumas in general, or trauma experience in general. Next, please. So it's probably very difficult to practice these while she is screaming on the telephone, but there are specific techniques that you can do in terms of de-escalation and prevention. It's best to do this when a person isn't screaming at you, and to practice them. And I'll tell you that personally, I've used these techniques for several decades, and I actually found them incredibly helpful, even though my son is in the borderline. He did have problems with anxiety as a teenager, and I found it especially helpful in grounding him and helping him deal with feelings of anxiety. So this is not just a borderline technique. You do have to know and have some idea of what can trigger a person, but I'm just going to go through briefly what the technique is, and I can actually demonstrate or in another session. But next slide, please. Great. So these are important important skills, okay? And it's important to teach the person how to ground themselves. Um, and and as I said, they're not just for borderline personality uh, diagnoses, but they're anyone that works with traumatized clients um, could find this useful. And it's not therapy. It's just helping a person calm down. Um, and 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 usually, let's say that when this particular person is screaming on the telephone, they are experiencing strong emotions and have probably been triggered. And what the event is or what reminder they got of a traumatized experience, I don't know. But if you work with the person, you can probably start to figure that out. Um, so this is when a person is overwhelmed by memories or strong emotions, and they're disassociating. They're screaming, but they're not in any type of contact with you or the other person on the phone. They're just in in a triggered situation, and they're being overwhelmed by memories and emotion. And it may have nothing to do with what happened today or what's happening now. Um, as I said, it's best to work with a person before when they're not being triggered at first, so that they get an understanding of this. Um, but a metaphor that I found useful is watching a movie, and what's going on is that when they're triggered, they're experiencing either a memory or a strong emotion, um, and and that's what is overwhelming them. And the idea is that the grounding techniques just help them step out of the movie theater, go someplace else. Um, I so I learned this way back when, a long time ago, when I was treating people with PTSD from uh, uh, the Vietnam War, but it still works. And um, and let's go to the next slide. Um, so the idea is that if you think about it in terms of neurobiology or psychology, the term that what's going on is that they're experiencing a very strong emotion or a very strong emotional memory. And the easiest thing to do is just to try and engage the patient and shift them into their senses. And the easiest and most dominant sense usually is vision. So ask, and they need a little trust with you, but if they can start to do this, you'll get um, significant response. So um, acknowledging them, you're seeming pretty angry right now. You're screaming at me on the telephone. Um, uh, can we try can we try to think about something different? Um, you know, as far as I know, no one's threatening you at your phone, and you're just with me. So let's try and stay in the present. Take a deep, slow breath, um, and tell me about what's going on in your environment. What type of phone are you using? What type of chair are you sitting on? What room are you in? So the idea is to switch the emphasis and get them talking about um, what they can observe with their senses. And that oftentimes really dramatically gets them out of the emotion and or the memory. And once they start to get out of that feeling, once they start speaking with less screaming or less intensity, it's important to ask them in terms like, how much emotion are you feeling now on a scale from 1 to 10? And they're probably just attempting, just looking at the emotion, just having some separation from it is the first step. And you can ask them to turn, if there's a dial or a knob, you can have them turn it down. You can have them clench their fists and imagine that the emotions in their fists, and then relax them and release them. You might have to do that 4, 5, or 6 times. If the person's even trying to do some of this, you're going in the right direction. And it may take 5 or 6 times, but it's very important for 2 reasons. One, you will gain confidence in your ability to help the person, and 2, they will gain confidence in your ability to help the person. So you can, and it's often important to know this ahead of time and have a discussion with the patient, but what's a safe place for them? And unfortunately, many people who are traumatized or have borderline personality disorder can't tell you a safe place. So you might have to build one for them. And that is using your imagination. What would a safe place be for you? And then, or an alternative approach is how do you survive? What strengths do you have to survive? To give them and focus more on their strengths. Next, please. This is a distraction. This is a distraction. And it's an important distraction because they're in a situation which is almost unbearable for them, and it becomes unbearable for those around them. As we described the patient today, that type of behavior becomes unbearable for everybody. So whatever you can do to get them thinking about something else is important. Even counting, or things like wiggling their toes, just anything to take the focus off of their current emotion. And then breathing techniques, I've talked about this before in terms of relaxation, but once there's some trust and they're using their senses, doing belly breathing is oftentimes very useful and can help calm them down. Next, please. So, as we said before, this disorder does respond to treatment. The issue with the person we're talking about today is that she's refusing to engage in treatment, but it's important to message to her that treatment can help while giving her a sense of that she's making her own decision. It can't be, you need to do this. It has to be, let's talk about this and come to a decision that works for you. So as I said, specific therapies, most likely DBT, have been shown to be more effective. DBT is not universally available, but almost any type of treatment, any type of relationship will help. Next, please. And then, so it's important here. This is a nice study about the treatment literature on borderline personality disorder. And it really shows that even people with severe symptoms, and I would say in the case we're discussing, that there are severe symptoms, that people respond to treatment if they get involved. More intensive therapies are not significantly superior to less, so just seeing a person once a week, as long as there's a good relationship, is very important and can work. And I think the one thing that I would say for the patient we're talking about, which is clearly a difficult patient, and I salute the person involved, but the important message to give is that treatment will help. And with her, the tack to take might be treatment will help if you will engage. Let's find something that works for you. Treatment will work if you engage in it. If you do it, you'll feel better over time. And things will work out for you better over time. Next, please. Okay, so I put a lot of this information. There's some questions about the omega-3 fatty acids. I did a real deep dive into them. A lot of information is in the appendix. But these are called essential because we don't make them. And these two essential fatty acids, EPA and DHA, come mainly from fish. So unfortunately, a study published last year that looked at blood levels. Okay, so many nutritional studies look at food diaries and people's recollection about what they eat. Not great techniques. But this is a US population-based study that looked at blood levels of nutrients. So over 95% of children and more than 2/3 of the adults had omega-3 concentrations in their blood below those associated with the US dietary guidelines. So you can almost assume that a person, the normal person, doesn't have the appropriate amount of omega-3. It's also important to understand that even though the two are derived from fish, they have significantly different effects on bodily functions. So EPA and DHA, even though they're both essential fatty acids, have significantly different effects, and especially on inflammation. Next, please. So most of the research on these fatty acids have to do with cardiovascular system. We still don't know exactly how they work, but they do affect the membranes in the cells and how permeable they are, and they do affect the modulation of second messenger cascades. So almost all hormones and other chemical messengers in the body trigger something on the cell wall, and then there's a second messenger system within the cell. So these fatty acids significantly affect those messaging systems. And they've been tried in a number of different disorders. But I took a look at this. This was a study back in 2020, but I thought it was very helpful in understanding this. So it didn't look at a specific diagnosis. It looked at all psychiatric diagnoses and looked at the types of symptoms that these fatty acids might affect. So next, please. So they looked at psychotic symptoms, affective symptoms, depression, impulsivity, and aggressiveness. harmful behaviors to others and self, and suicide risk. So um, there's no evidence that these fatty acids affect any type of psychotic symptom. And this is across bipolar, schizoaffective, and schizotypal personality disorder. So if this patient was indeed experiencing psychotic symptoms, um, uh, uh, the essential fatty acid supplementation would have no effect, or definitely would have effect. However, for depressive symptoms, uh, uh, using supplements with higher doses of EPA added to antidepressants did have a beneficial effect in mood. So they do affect mood stability and depressive symptoms. And here's where it makes a difference. But if you reverse that ratio, lower doses of EPA and higher doses of DHA, there's no benefit. So, and actually I looked at these studies, most of the studies had only EPA when you looked at depressive symptoms. Next, please. Thank you. So, and this is this, so across diagnoses, so this is borderline personality disorder and attention deficit disorder, just using fatty acids showed significant improvement in impulsive discontrol and aggressiveness. So you didn't have to use any other medication, just the fatty acids. And this is a meta-analytic study, so they combined a number of different other studies, and there's established benefit. Now, so having a person with significant aggression and discontrol, if they were willing, trial this supplementation that could show some benefit. And then using the fatty acids with Depakote also showed significant benefit, especially on impulsive and impulsivity and anger in bipolar patients. I'm sorry, in borderline patients. And then there's also significant reduction in self-harming and parasuicidal behavior. And that is independent of change in depression score. Okay, so this is the McLean screening instrument. It's 2 pages. Have you or your closest relationships been troubled by a lot of arguments or repeated breakups? That's an impulsivity symptom. Have you deliberately hurt yourself physically, cut, burned, etc.? Suicide attempt. That's impulsivity. Have you had at least 2 other problems with impulsivity? Eating binges, spending, drinking too much, verbal outbursts. That's impulsivity. So, and then, have you been extremely moody? Have you felt angry a lot of time? How often have you acted in an angry or sarcastic manner? So, affective dysregulation. So, 5 questions in the screening instrument. 1 or more, or all of them, would indicate that there would be possibly some benefit and not a lot of harm from trying the essential fatty acid supplementation. Next.
So should we go to the patient and see, did you want these answered about the patient?
Yeah. Just so when we talk about the patient at the end, I'm almost done. So so here's the other questions. So there's 5 other questions, and these are more the psychotic symptoms, and derealization symptoms, chronically feeling empty, being distrustful, things were unreal, having no identity, avoiding feeling abandoned. none of these symptoms are responsive. So if a person checks a lot heavy in this page and not so much in the first page, probably not a good match. But if a person has a lot of the first page symptoms and very few of these, or if they have all of them, um, the impulsivity and uh, affective dysregulation symptoms might respond, and these symptoms won't. So just to give you an idea on that, and then I'll talk specifically about the patient when we get there. Next, please. And then I'm just going to go, okay, so quickly over this. Um, um, having trauma early in childhood significantly affects a person's response to antidepressants. Next, please. Yeah, you read this. So especially the earlier the trauma, the more likely they're not going to get better with using antidepressants. Next. So, so if the response is significant or the non-response is significant, you're almost double. Um, um, your chances are almost double to not respond to antidepressants if you were experienced childhood adverse events from 4 to 7. Okay, next, please. Yeah, next, please. And then there's a meta-analysis. I'm not going to go over that, but it's been shown that specific antidepressants are much more likely to work in people that have experienced trauma, and this also means people who are have borderline syndrome. Next, please. Great.